side when we check the thyroid, and we have now moved our patient back to the front, right? Taking everything away. We are going to watch you breathe. Kind of just kind of sit right there. There you go. There you go. Look at her face. Look at her coloring. Make sure she's not struggling at all to breathe. Watching her chest move. Okay. We don't necessarily have to always be this obvious when we're working with our patients, right? Because there's some things we can do without them really paying that much of attention to what we're doing. At this point, I want to do our inspection of the breast. So we're going to have an assumption here that there's nothing here. Everything is closed off where the patient has some privacy. So I want you to raise your hands over your head as high as you can. Very good. Now bring them down and put them on your hips. Squeeze real tight. Okay. Now what you'll be noticing is the distribution of the skin. If there's any puckering or whatever like this. Okay. Which way the nipples are going, right? Looking at the vascular on her chest. Now take your hands like this and squeeze really, really hard. And once again, this gives us an opportunity to look from side to side for any puckering. Okay, now I'm going to put my hands out like this, and I want you to put yours on top and just kind of lean this way off the table. Without the top, the breast tissue would come away from the wall of the chest, and we're able to see if there's any dimpling or anything that looks unusual. Very good, thank you much. Okay. Now, at this point, we will have our patient turn this way for us so that we can use the mirror here to help you see what I'm doing. In the clinic setting, you would not have this. The patient would continue to look forward, and you would just move to the back. But notice, once again, I'm on the right side of the patient, or right side of the bed. Whenever we are assessing the chest and the lungs, we want to have our patient just kind of sit straight for us, just as straight as you can. Okay. We want to know if there's any pain or tenderness anywhere here. Nothing hurts you at all? Okay. We can work our way all the way down her vertebrae. Nothing there? Okay. Then with our fingers, I want you to say, you can do it with the ulnar side or you can do it with the tips of the fingers. We're now going to do what's called what? Vocal firmitus, huh? Okay. So I want you to say 99.
99.
It can be 99 or 111 because we live close to 99 and most people say 99. We say 99. So 99, please.
99.
Again.
99.
And again.
99.
Okay. Now we have 12 or so ribs that are floating along through here. And we're going to stop right in this vertebral angle, right through here. So she says 99, 99, 99. Our fingers are going to come together at this angle. Can you see this? Where the thumbs are together now. All right? Look right into the mirror. And then for my patient, I want my patient to take a deep breath in, as deep as you can. Deep breath in. Very good. And blow it out. And this is called expansion. We expect these fingers, these thumbs, to move equal distance on each side when she takes a deep breath and blows it out. Did you see that? Can you repeat it one more time? Real good deep breath. Very good. Now, in order to get this, your hands are not just like down, 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 but your hands are lightly on her back at this point. Okay, just very lightly so that your fingers can move. Okay, you don't have a real vice grip. So one more time, please. Deep breath. Very good. All right, we okay with that? Okay. At this point, we can, since we are in the costovertebral angle, we can go ahead now and check for CVA tenderness, right? Okay. So why not? All right. Patient may be a little bit surprised, but we're going to do an indirect percussion. Okay. No pain?
No.
Not until now. Okay. Okay. Now, when we start to percuss, we want to percuss the lungs. So we want our patient now to hug herself. So I want you to lean forward, kind of push these lungs right back here to me, and just let everything go. And we start to percuss. Now, with the percussion, we want to use the middle finger. We want to make sure that it's planted down firmly, and all of the other fingers are lifted from her body. If the other fingers were left down, this would dampen the sound. Okay? We're going to use our middle finger of our right hand, if we're right-handed, in order to percuss on what's called the DIP, the distal interphalangeal joint. Okay, right here. Okay? So we're going to just go like this, just like a downward movement. Okay? The closer you are. And we're trying to use the tip of our finger as we do it. Okay? And we do this from side to side, and we try to avoid the scapula, okay? Have you take your arms out this way, still hugging yourself. You can percuss anywhere on the body, but just remember when you're over the bone, it's going to be what kind of a sound? A flat sound. When you're over a muscle, it's going to be dull, right? Then when you're over the lung, it should be resonant. Okay, and when we're over the gastric bubble, it should be tympany, right? And it's hyperresonance if there's a lot of air that's trapped in there, correct? Okay, so as we are percussing, we're trying to determine the lung field, is what we're doing. And typically, you'll go from side to side. You don't have to get carried away with it, but just enough. And notice how we want to compare one side to the other. Okay, are we all right with that? Okay, so it's all over. All right. Once we've done this, we have an idea now of how far her lung tissue spreads through this particular area. So in order to do something that's called diaphragmatic excursion, we want to now decide that have our patient breathe in. And as our patient breathes in, because the diaphragm goes down when the patient breathes in, we will now percuss down. When we get to an area where we go from resonance to what? Dullness, because now we're at the diaphragm, we want to stop and draw a line, right? That means that our diaphragm has gone down that far. Okay? So patient, take a deep breath. Hug yourself again, lean forward. Good. And I got my little pen. And we have our patient take a deep breath and hold it. Deep breath in and hold it. Okay. Now, because one side of the body mirrors the other, once again our patient takes a deep breath and she holds it for us. Notice I did not start at the very top. Okay? Our patient cannot hold her breath that long. Blow it out. Very good. Now we do something different. When the patient blows her air out and keeps the air out, the diaphragm goes up, right? Okay, so in order to determine the distance, that excursion, before it went down, before it goes back up, we go to the line that we drew earlier, and this time we percuss up, okay? Our patient takes a deep breath in, and she blows it out and keeps it out. Do not breathe back in. Okay, you can breathe now. Okay. Okay, ready to do it again? Mm-hmm. Deep breath in, blow it out, keep it out. Okay, breathe normal. All right. At this point, we will now take our little centimeter ruler and we'll measure. Typically, the distance is anywhere from 3 to 5 centimeters. I think your textbook says 5 to 6 centimeters. I like 3 to 5. On this measurement, as well as I can see today, I'm looking at 3 over here, and I'm looking at about 3 and maybe a quarter at most. Nope, 4. 4 there. Someone needs to get the glasses. And 4. 4 and a quarter. Okay. So what you can do, since you may not have your chart available right away, you can just, if you have a little paper covering like this, you can write down the number here and then later on put it on your chart. And that's a perfectly good range for diaphragmatic excursion that she has now. Okay. So now that we're finished with this, we can move this over to the side. And now we're ready to listen to our patient breathe. We're going to take our diaphragm up the stethoscope, and we're going to have our patient breathe in and breathe out before we move the stethoscope. We're going to have this snake-like pattern as we go through, where we're going to go from 1 to 2 to 2 to 3 to 3. You got me? Okay. And then when we are finished with the back area, we'll get about 12 to 14 areas covered here on the back. Then we'll have our patient bring her arms out like this, or you can have the patient take her arms up like this. And then the whole idea is to use the axillary to listen in the anterior region of the lung. On this side, listen anteriorly on this side, medial over on this side, medial down here, we're moving down a little bit, and then mostly lateral, and then lateral. Is that all right? Okay, let's see how we do. Okay, patient, barrel chested again. Well, kind of hug yourself. And we're going to start up high. Okay, deep breath each time I touch you with the stethoscope. Let me know if I'm going too fast, okay? Very good. Now raise your arms for me. Good. Deep breath. Again. Deep breath. Again. And one last time. Okay. Now, because our patient does not have hair on her body, a gross amount of hair on her body, because she has no clothing on her body, my stethoscope, I can put it directly to skin to stethoscope, right? There's no interference. I don't hear any rubbing. I don't hear anything but her breathing, which is really good, all right? Now, at this point, we start to listen for adventitious sounds and all the way through. We're listening for our crackles and our wheezes and the rhonchi and all of this, that, any kind of a friction rub, anything that might be there that is abnormal. But right now we're hearing equal breath sounds on both sides in all positions, so there's nothing that's unusual with her right now, okay? So therefore, in a regular clinic setting, everything's normal, color is good, skin is warm, pulses are great, no heart problems. You can stop right now, but we're going to go on and do some additional tests, right? Okay, so we're going to do something called bronchophony, okay? And bronchophony is where we're going to have our patients say 99 again. Because we are listening through the stethoscope, we expect that 99 to be a little muffled, right? If there was consolidation, that 99 would sound like it was broadcasting in the room, okay? Okay, so let's go through bronchophony now. We do not have to go in 12 or 14 different places, right? We're going to just do 6 places. That's enough from one side to the other. So patient, if you once again will go back to your barrel chested, just kind of hug yourself there. And say 99 each time the stethoscope touches your back.
99, 99, 99, 99, 99, 99.
Okay, very good. Did you notice that the distance also was broader, wider than when I was listening, when I was auscultating? Okay. At this point, we're now going to do something called egophony. And this is where the E should sound like E. Once again, it's going to be really muffled. But if the E starts to sound like A, we have a problem, don't we? Okay? All right. Okay, let's what would the problem be? Once again, fluid, something's there. Okay. All right. So let's say E each time the stethoscope touches your back.
E, 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 E.
Okay, good deal. Now one last one. We're going to do something called whisper pectorality. Whisper pectorality. At this point, we're going to have her whisper the numbers 1, 2, 3. Just whisper 1, 2, 3. And what I'm expecting to hear is basically nothing, right? But if 1, 2, 3 starts to sound like 1, 2, 3, then we know what? Once again, we're back to our usual problem: consolidation, fluid, blood, whatever might be in there. Okay? So, let's do 1, 2, 3. Okay?
1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3.
And to tell you the truth, when I started out earlier up here, because my stethoscope was not really fitting in my ear, I could hear the 1, 2, 3, but as I moved down and I started to hold it, each time I touched her, I could not hear it at all. I was even thinking, is she saying it? Is she trying to play a little trick on me? And she just said, okay. So that's it. That's it. Now, let's go this way a little bit. Turn around this way. Now, for our exam, we will not evaluate the lungs anteriorly, right? But if you were doing that, evaluating the lungs anteriorly, you would do the same thing. You would have your tactile firmitus, okay? And you could do both of them at one touch in the front. Just have her, as she's breathing, we could go here, we could go in here, we could go right in this area, and then we could go up around through here. We could even do our diaphragmatic excursion through here. Deep breath in. See? No problem at all, right? We could do a little percussion if we wanted, okay? We could do it all. And then because the lungs are sitting high, we would listen up high. We'd probably even be above this clavicle, okay? And we'd start our listening one side to the other, to the other, to the other, here, here, as we worked our way through, okay? And then back, the same principle, okay? Diaphragmatic excursion, okay, you would not need to do that up here. If you wanted to do the bronchophony, echophony, whisper, pectoriliquy, you can do that as well. But remember, because our exam, you will be doing your assessment of the heart, we do not want to have you do the assessment of the lungs in front. Okay? If you had a patient who had a cardiac problem, of course, other severe chronic respiratory illnesses going on, we want to assess in the back, right? And in the front as well. Okay, we good there? Now, let's go back and rewind the tape a little bit and pretend that we didn't do anything in the front. And we're only talking about our exam now, the way we're going to do it for your midterm exam. So once our patient turned to the front, we would stop right here. Okay? Now this is a time when we want to do something like this. We would take the fatty part of our fingers. We're going to palpate for thrills. Remember? Now while we're here, we want to start here. And since our patient is a lady, we always kind of lift up the breast tissue just a little bit. To me, it doesn't matter what size the breast is, whether the breasts are large, small, or whatever. I always take my hand and I go under just a little bit. Okay? So we're going right here, and we're right here. Okay? And we are, at this point, we can even determine her PMI if we like. Could we not? We could have her take a deep breath and move forward for us. Because we're right around the 5th intercostal space, midclavicular line. Okay? We could even do one of these, or we could do this as well, right? Okay, now she straightens up, and we can continue on with the thrills. We're here. Now notice how this hand is going to go straight up and down, right through here, okay? And right here. Now, we're not so much worried about over here because the heart is basically lying on this side, is it not? Okay, so we're here, we're here, we're here for thrills. If we were checking for heaves, this is the time when we want to feel with the balls of our fingertips in various areas to see if there's any lifting at all. So there's a difference between thrills and heaves. Okay? Now in your class, when you lay the patient down, you're going to go down as well and look across the patient. Have the patient bring her legs up just a little bit and her head up a bit. And now you're going to look to see if you see any bounding off of the chest when the patient is lying down. That's another way to look for heaves, okay? Okay, so we did our thrills, we checked for heaves, okay? Now, let's determine some landmarks. As we look here, when we think about the midclavicular line, clavicle, the midclavicular line is sort of coming in a little bit to the medial side of the nipple, or the areola, don't you think? Okay, so when we think about that, we come down, we come down, we come down. Okay? We think about the sternal border. We're right here in the middle. Get all the landmarks up. Because when we think about our second intercostal space at the sternal border, right? We think about the left and right second intercostal space at the sternal border, don't we? We think about the third and fourth intercostal spaces at the sternal border. And then we think about the fifth intercostal space where? At the mid-clavicular line, don't we? Okay? All right. Now, when we think about our anatomy, what is it? We call this, what? Aortic? Pulmonic? That third intercostal space is sometimes called Erb's point, isn't it? But once we get down to the fourth intercostal space, what are we looking? What's our anatomy there? Tricuspid. Okay, and that's our valve, right? Okay. Now we're also thinking about the fact that that right ventricle is lying what? Over most of this, right in this area as it lays in here, the right ventricle, with our left ventricle being more off to the lateral side, right? So we have to think about how this heart is lying in here. So we got our tricuspid valve, and then as we get around the fifth, over around the midclavicular line, where are we now?
Mitral.
The mitral, right? Okay. So as we work our way through, let's start off using the diaphragm. The diaphragm is going to pick up all of those loud sounds. S1, S2, and S4, and maybe mitral regurgitation. Okay, something of that nature. Okay, and our bell will pick up those low sounds, right? And it's going to pick up what? What did we leave out? Murmur. We left out 3, didn't we? Okay, S3, murmurs, and now we're ready to pick up mitral stenosis. Mitral stenosis is a big deal, right? Yeah, especially, middle-aged women, menopausal, hormones. Okay. All right. Not for this. Not here to be concerned about any of that. Okay. So what we want to do now is to find where the second intercostal space is. So start up here with her clavicle. And it's sort of like playing the piano. You can feel the bone in there, so you're in these spaces between the bone. Okay? So let's go here. And notice I didn't go flying through. I'm taking my time. I'm listening to what is happening here. Now watch this. We have to get over here, don't we? So why don't we take our stethoscope like this, and as we work our way down, then we will lift up, okay, and just kind of lay it in that area. Are we okay with that? Okay. Now, because we want to start listening for murmurs and for any kind of little stenosis or anything of that nature, we want to go back to this area again, okay? And we have our bell. This bell is, remember where the PMI was? Okay. This bell is going to be lightly placed in that region. We want her to take a deep breath in, lean forward, hold that breath for us. Okay, patient, blow it out. Okay, sit back a little bit. And what I like to do is just what I like to call bell back up. Okay? So we can take it this way if we like, and bell back up those same places that we were before. Okay? Same areas. And it's the opposite direction. Did you notice that? So we came here, fourth, third, second, right? Okay. Now, let's see what the heart sounds like when the patient lies down. So we have our patient lay down. As the patient is lying down, notice the bed is about 30 degrees or so. We pull out this so that our patient can rest her legs, even no problem at all. And remember that thing about heaves? Now's a good time to sort of bend down and look across, straight across her chest. You can bring your legs up just a little bit, sort of relax everything. Very good. And later on, we could kill two birds with one stone if we wanted to. We could have her bring the legs up even higher, bring her head up as well, and now look across her tummy, really bulging and all too. And that I would suggest later on, okay? But we could do all that at the same time. So once we look across for heaves, okay? If you wanted to, do you need to go back and do the thrills and the heaves all over again? I don't think so. Okay, we've already done enough, but if you wanted to, you could. Okay. At this point, we're going to repeat the same thing that we did when she was sitting up. Okay. We're going to start here at the second intercostal space, at the sternal border on the right, and then go over to the left at the second. Then do our third, our fourth, fifth. Work our way around here, fifth. Okay. And then we're going to have a turn over.
So auscultation all over again.
Mm-hmm. Same thing all over again. Our patient okay? Okay, patient. Okay. Now, remember once again where that midclavicular line is. So think about the nipple, think about midway on this clavicle and coming down. Okay, so we can go like this and take it up if you like. Oops, just a little bit patient. And if you had not checked the pulses, you can do it now. Or you may have it turn a little bit this way and check it here. Oh, boy, is this strong. Very good. Okay. Now, we want to have our patient now turn to her left lateral recumbent position. And before she does that, we're going to take this stethoscope and put it back in the fifth intercostal space. Oops. I think you're fine. You're fine. We can hold it there, we can hold it here. Now we want our patient to go turn just a little bit, and we go with it as she turns. We don't go around the other side of the bed. Take a deep breath in and hold it. Okay, blow it out. There you go. Now you can come back flat. What that does is push the heart up to us again, close to the wall. And now we walk our way back up. Oh, this heart is just having a ball here. Now, we're going to have our patient hang in there. For our exam, we will now go up and feel her temporal pulses, palpate those out. And each time we palpate one pulse, we put our bell part of our stethoscope down to the pulse, and now we're listening for bruits. Okay? So she's lying down. She doesn't have to go anywhere. She's just right here. Let's check the carotid again. And hold it. Open it up. And come this way again. Now, while we're doing this with the carotid, we can also check her JVD, jugular distension, see if there's any bounding at all. I can see a little bit of her pulse rate sort of showing right under her skin right here. But her heart is nice and strong and a steady beat. Deep breath in and hold it. Very good. Okay, now blow it out. All right. Now, what we want to do is now come down to the xiphoid process and sort of work our way just a little bit to the left. And what we're going to do now is to try to see if we can locate her abdominal aorta. Not always easy. It'll be about the size of a quarter. Let's see what we get in here. In addition to this, we want to think about her renals, her iliac, and down into the femoral area. Now, because we cannot palpate the renal and the iliac, we're going to basically use her tummy here and divide it up into landmarks, into 9 landmarks, okay? 9 squares. And we want to think about the renals, the kidneys, where are the kidneys located, and then try to see if we can hear anything up here. We're going to think about coming right around the umbilicus or a little bit above to where we think her renal or her iliac would be. And then we have to come way down and get on the inside to be able to determine where her femoral pulses are. Okay? At this point, when we get to the femoral region, this we can palpate. So once we can palpate the femoral, now we're able to once again put the stethoscope, the bell part, back down to the femoral region and listen for any bruise. Okay? Okay. So remember, we can't palpate right in here. And it's still the bell. And because our patient, you want to take your hand under mine, and we're going to locate your, we can do this. If you have young people who get a little ticklish and whatever like this, you can put their fingers under, between yours, and then have them find the pulse themselves. Then that way you can palpate it, okay? We're not going to have her take her finger all the way down here. We're in this region. You see where we are? Okay, on either side of, basically, the mons pubis or the labia majora. Okay, but right within the leg, okay? All right. And then we would go ahead, take our stethoscope, and we'd listen in that region and in that region. You guys will have to do that for your exam as well, okay? Now, at this point, once we've got all of this done with the bell, because we like to get rid of instruments real quick, you can now, since you haven't really roughed up the tummy and did any palpation or anything like that, you've just listened for the vascular, you can now go back and listen to the bowel sounds with the diaphragm. Even though we're not doing the tummy, we want to get rid of the stethoscope. So at this point, you listen for bowel sounds. To listen for bowel sounds takes longer than we normally do in the hospital setting, where we sort of make the sign of the cross and keep going. Okay, it takes a little while. So we want to listen. Oh, also I want to point out, you did notice that as I was doing all of these pulses, I compared one side to the other, right? To the other, except for the aorta. Then I went with the renal one side, iliac, femoral. Okay, all right, gotcha. We're going to do the same thing here with the bowel sounds. Doesn't matter where you start. We're going to do it in 4 quadrants, okay? In the interest of videotaping, we're going to move on though, okay? Because you do need to give it about 3 minutes or so in each quadrant. Not much going on in here, patient. Quiet.
It's 3 minutes per quadrant?
I would try to do that, especially, in the condition where you all are working in hospital and all, we're louder here. Much louder here. Now you have to think about the anatomy, right? You know what's over here on this side, right? The lower left quadrant. Okay. So once we've done this, now we're done with the stethoscope. Now our patient, you have shorts on over here, right? So can you remove this and then the shoes and socks? You can get to me and put them down there for you. You're going to just flop them down? Okay, make some up. Okay, now, in order to finish with our pulses, okay, have your patient, let's pretend our patient didn't sit up. Our patient's still down, okay? Now you see how we could have gotten into the femoral, okay? What I would also recommend is, since you're here already, that you would go ahead and check the inguinal nodes. Don't you think so? Since you're in this region already, so when you do your femorals and all, do your inguinal nodes, and then you're ready to go. Coming out of that region, you want to take the back of your hand, and remember, we got to do the temperature thing again. Okay, because we haven't been in this area yet, right? Okay. Now, as we're doing this, we're looking at her skin, looking at for hair distribution and that kind of thing, looking at her color. All right, any lesions and all that might be there. But we're also going to this area. We're going to try to do feeling for nodes. We've got our nodes to do here in the popliteal area. And then we're also going to try to detect pulses. We're going to push up a bit here. And they're not always easy. You may want to just kind of have her drop her leg right into your hand a bit to give you a little bit more of a weight. Okay. Just kind of let it go for me. And I'm not hitting. Okay, so let it go. Now we'll have her rest out. Rest your legs, lay your legs all the way out. There you go. We'll work our way down. Now if we look right here, there's a ligament that runs right here from the great toe up on the dorsal surface. Now we want to go right here, just kind of come right up a little bit with both fingers, 2 fingers at least, and we're trying to determine the dorsalis pedis pulse. And remember those pulses are from 0 to 3 plus, with 3 plus being bounding. And then we want to go over here to the medial side, right behind her little malleolar area, and get her pulses there. In addition, while we're down here as part of the vascular system, we want to check the capillary refill. These toes are really chilly. Yeah, oh my goodness. I'm sorry. But they are, the color is coming right in real fast, even though they feel like they belong to dead, a dead person.
Always her fingers.
Always cold like that, huh?
Cyanosis.
Yeah, very good, very good. Okay, and we're all done with what we need to do. Thank you so much. Okay?
Yay, thank you.
So cold. Yeah, thank you.